So now that we've discussed the typical features of autoimmune diseases that cause arthritis and discussed autoimmune testing, we can go on to discuss a practical approach to arthritis. As with everything in medicine, there are often clues in the history that can help clarify the diagnosis. Important details to obtain are the arthralgia distribution, the onset and duration of disease, as well as the presence of morning stiffness, which may suggest an underlying autoimmune arthritis. The presence of systemic symptoms may also suggest an underlying autoimmune disease, and is also important to take a good drug history, specifically to see if any new drugs have been initiated which may be associated with either triggering or flaring underlying autoimmune diseases. A good review of systems is also important to try and determine if the patient has symptoms of an underlying autoimmune disease. Specific symptoms to inquire about include a rash, particularly a photosensitive rash, a malar rash, the presence of purpura to suggest small vessel vasculitis, or erythema nodosum to suggest another systemic autoimmune disease. Ocular disease, particularly a red painful eye, may suggest underlying uveitis or even scleritis or episcleritis, which have associations with autoimmune diseases. You can inquire about sicker symptoms by asking if the patient has abnormally dry eyes or mouth, and this may be suggestive of Sjogren's syndrome. You can also inquire about paresthesias, particularly if there are tingling sensations affecting the arms and legs, which may suggest mononeuritis multiplex, which is associated with ANCA-associated vasculitis, or other neurological manifestations representing another autoimmune disease. You can ask about hemoptysis, which may suggest respiratory tract involvement or pulmonary hemorrhage, which may suggest an underlying ANCA-associated vasculitis, although hemoptysis when severe is usually the presenting complaint. And you can ask about ulcers, particularly aphthous ulcers, which can commonly affect the mouth or oral mucosa, and this is associated with lupus and other connective tissue diseases. You can also ask about oral and genital ulcers, which is associated with Behçet's disease. Then you can look for clues in the medical history, particularly if there is a personal or family history of autoimmune diseases, as this makes the patient at a higher risk of having an underlying autoimmune disease. Then a good clinical examination is important, as there are often many signs that can be detected which can suggest an underlying autoimmune disease. Obviously, a good rheumatological examination of the joints is important to identify the affected joint distributions and any evidence of chronicity as evidenced by deformities. You can also assess the degree of disease activity by assessing the degree of tenosynovitis. A full systemic examination can be done to look for evidence of extra-articular manifestations. For example, a cardiorespiratory examination may reveal evidence of interstitial lung disease or pulmonary hypertension, which would suggest an underlying connective tissue disease, or autoimmune arthritis. Abdominal examination may detect splenomegaly, which may be present in Felty's syndrome. A full neurological examination is important as it may identify multiple peripheral neuropathies, which would suggest mononeuritis multiplex and therefore diagnosis of possibly ANCA-associated vasculitis. The eyes are an important site to examine, as ocular inflammation is associated with various autoimmune diseases as discussed. A thorough examination of the skin is important to try and identify any abnormal rashes that may help clarify the diagnosis. And lastly, looking in the mouth is important to look for evidence of oral ulcers. Then there are several clues that can be obtained from the basic investigations. For example, markedly elevated inflammatory markers may suggest an underlying autoimmune disease, along with a anemia on the full blood count and possibly cytopenias, which are associated with particular autoimmune diseases. Eosinophilia would be suggestive of EGPA, and a normal or only mildly elevated neutrophil lymphocyte ratio would be more suggestive of an autoimmune disease with disease flare, as opposed to the main differential diagnosis of sepsis, which typically has a very high neutrophil to lymphocyte ratio. The presence of acute renal impairment is also suggestive of particular autoimmune diseases, particularly lupus and the ANCA-associated vasculitis, as well as anti-GBM disease, where anti-GBM antibodies can be done if this is suspected. Chest imaging to detect pulmonary disease can also help clarify the differential diagnosis. For example, hilar lymphadenopathy, visceral nodulation, and evidence of fibrosis may be suggestive of sarcoidosis, and the non-specific interstitial pneumonia pattern with bilateral ground glass opacities with subpleural sparing would be suggestive of an autoimmune arthritis or connective tissue disease. Evidence of pulmonary infiltrates or pulmonary hemorrhage would be suggestive of an ANCA-associated vasculitis. Based on the history, clinical examination, and investigation results, a differential diagnosis should be formulated. While it is tempting to consider the rare and complex diseases, one should firstly consider the common differential diagnoses, particularly mechanical trauma causing arthritis and infection, whether it be a primary joint infection like septic arthritis or something like a viral illness which can cause systemic myalgia and arthralgia, or a secondary reactive arthritis. You should also consider crystal arthropathies because these are also relatively common. If the patient's clinical presentation does not fit one of the more common differential diagnoses and appears to have multi-system involvement, then a differential diagnosis of an underlying autoimmune disease should be considered, and this can be tested for with a range of different tests as discussed in the previous video. But as discussed previously, it is important to take a targeted approach to only order the appropriate autoimmune serologies for the specific differential diagnoses that you have in mind. Joint aspiration should be considered if it is feasible and there is relatively high diagnostic yield, particularly if you're suspecting a septic arthritis or a crystal arthritis. Joint imaging, particularly X-rays of the hands, can be useful to help distinguish the different types of autoimmune arthritis. Rheumatoid arthritis typically has periarticular osteopenia and symmetrical joint erosions affecting the metacarpophalangeal joints and proximal interphalangeal joints with sparing of the distal interphalangeal joints, as opposed to osteoarthritis where the mechanical damage results in Heberdin's nodes, Bouchard's nodes, and joint space narrowing, along with subchondral sclerosis and bone cysts, and periarticular osteophytes. Asymmetrical joint space narrowing can also be seen in X-rays of the large joints. In contrast, the seronegative spondyloarthropathies can have typical pencil-in-cup deformities from destruction of the interphalangeal joints, and ankylosis may be present in the case of ankylosing spondylitis on spinal imaging. After basic blood tests, imaging, and autoimmune serology, and sometimes further more specialized testing is done, the specific diagnosis is often made and the disease can be treated appropriately. Sometimes a specific diagnosis cannot be made, but a broader diagnosis can often be made based on the clinical features and available positive and negative results. These cases are often treated empirically using immunosuppressive therapy that targets the postulated aberrant immune pathway. In terms of management points, analgesia is important to relieve the joint pain, although treatment of the underlying cause is most effective. Commonly used treatments for autoimmune arthritis include non-steroidal anti-inflammatory drugs, which are particularly useful for seronegative spondyloarthropathies, and steroid therapy, which is generally effective for all autoimmune diseases. Once a specific diagnosis is made, you want to investigate for other complications of the disease and look for underlying secondary causes of the disease. For example, if the patient has an underlying dermatomyositis, you will need to investigate for systemic manifestations of connective tissue disease and investigate for an associated malignancy, particularly if the patient has a TIF1 gamma myositis-specific antibody. If the patient is found to have a mixed cryoglobulonemic vasculitis, then they need to be investigated for underlying connective tissue diseases and hepatitis C. Ultimately, in order to treat the patient's symptoms, you need to diagnose and manage the underlying primary disease. Here is a flow diagram I created which summarizes the investigational approach to arthralgia and summarizes the key features of underlying etiologies, particularly autoimmune etiologies, followed by the appropriate investigations that can be ordered based on the clinical manifestations. This flow diagram is here for you to review and will hopefully help consolidate the content that has been discussed throughout this video series. And that brings us to the end of this video series. I hope you now have a better understanding of the various causes of arthritis and a better understanding of the various autoimmune etiologies for arthritis. The key take-home messages of this video series is the approach to arthritis as outlined in this slide, along with the slides from the other videos outlining the typical features of various autoimmune diseases. I hope you now have a better understanding and approach to working up a patient presenting with joint pain, and have a better understanding of how to investigate for underlying autoimmune diseases. If you like this content, please leave a like, comment, and subscribe to the channel. All the best.